All right, it looks like we've hit a plateau, and I'm sure a few people will join us late, especially if they're just finishing up in clinic. But I would love to welcome all of you to the 2021 Jeffrey and Joyce Myers Lecture Series. And it's our 13th year with this lecture being given. And I just want to express my gratitude to the Myerses for continuing this tradition and for giving us an opportunity to hear from world-class people in optometry like tonight's speaker. So our honoree this evening is John Carroll Whitener, OD, MPH. I'll give you just some brief highlights because I know you'll hear more about him as he speaks. He graduated from the Illinois College of Optometry, which we'll forgive him for, and he received his master's degree in public health at UNC Chapel Hill. He provided clinical care in the Army Reserve at Walter Reed for 15 years and served as an optometrist in both Vietnam and Operation Desert Storm. I got to know John in his role as the Assistant Director for Federal Relations with the American Optometric Association. And although he staffed the Health Promotion and Disease Prevention Committee, that wasn't how I got to know them. He was instrumental in creating and directing the American Optometric Association's Council on Research for 20 years. And under his mentoring and tutelage, I had the privilege of chairing that council for 17 years. And during that time, my estimate is that the Council on Research's Summer Research Institute raised $70 million for optometric research, mostly from the federal government. And I will tell you from a personal point of view, John Whitener was hugely instrumental in those efforts. He knew everybody. He chatted us up to everyone who would listen and to that effort. He worked for many years for the inclusion and eye and vision objectives in the U.S. Department of Health's Healthy People Initiative. And for the first time, Healthy People 2010 included 10 vision objectives for the nation. He was the lead staff person launching those activities with a program that AOA called Healthy Eyes, Healthy People. And John's deep commitment and enthusiasm for better health outcomes, better vision, and better lives for people in the United States is unparalleled, in my opinion. So with that, John, we're anxious to hear your talk, and we're all yours. The floor is yours.
Oh gosh, thank you, Carla, for your kind words of introduction. I met Carla when she was a graduate student at UC Berkeley at probably our very first Summer Research Institute, and I've watched your amazing career over the years. And a big thanks to Jeffrey and Joyce Myers for sponsoring this lecture, this honor. It's an unexpected surprise for me. When I was adjunct faculty at Pennsylvania College of Optometry, I promised myself to always try to present an interesting lecture, hopefully in which everyone could learn something. So this evening, I'll do my best to make your time with me worthwhile. And if you stay till the end, I hope to leave you with a smile on your face. I was somewhat hesitant to present in this lecture a very personal part of my life in the context of my optometric career. But recently, a friend reminded me of the words of William Faulkner: "Never be afraid to raise your voice for honesty and truth. If people all over the world would do this, it would change the earth." Public health. Public health. Two words I never imagined I would hear daily, repeatedly on TV, radio, and social media for the past 2 years. Although this presentation will focus on my public health career in Washington, I believe it's important to understand how I got there. And it began in my junior year in high school when I began to think about what to study in college. I decided I wanted to be an optometrist. I didn't know much about optometry, but in my town, I knew one optometrist, Dr. Boss. My aunt was his receptionist. I remember a small plaque on her desk that read, "Optometry, the art and science of vision care." That phrase really struck a chord with me. And in our town, Dr. Balls was financially very successful and a very charismatic person. Very charismatic. He eventually left his wife and 3 kids and practice to move to Florida with my still married aunt. Quite a scandal in my small town. But I like the idea of becoming a health professional, helping patients to see, being my own boss in private practice, and the possibility of making big money. Since I wanted to be successful like Dr. Balls, I decided I would follow his advice, his recommendation, and go to his alma mater, which was Illinois College of Optometry. I didn't even check out other schools. I went from a small Lutheran college where I lived at home to save money to the big city of Chicago. Approaching graduation, I had only had about 100 patient encounters. I felt very unprepared to set up practice. There were no externship programs available, so how could I get more patient experience and training? My answer was the military. So during my senior year at ICO, I went to a Southside Chicago recruiting office for the paperwork and an induction physical exam. I write about this humiliating experience in my memoir. I survived the physical, but to complete the questions on the medical history form, I confronted a moral and potentially life-changing dilemma. The question on the form was, do you have homosexual tendencies? Homosexuality was classified as a mental illness by both the American Psychiatric Association and the military. I could have told the truth, checked yes, and come away with a 4F classification, which meant that I was undesirable, unfit for military duty. I could have avoided the military draft altogether. But I knew that the consequences of a 4F classification could drastically affect my optometric career. In North Carolina, where I wanted to be licensed to practice, a doctor's license could be suspended for moral turpitude, meaning conduct considered contrary to community standards of good morals. This decision could deprive me of practicing optometry. Moral turpitude and its consequences evolved from England's ecclesiastical laws relating to human flaw, or falling from God's grace. North Carolina and many other states also had a sodomy law titled Crimes Against Nature, which carried a penalty of up to 10 years imprisonment and $5,000 fine. So with the possibility of losing my license to practice, or even worse, serving time in prison, of course, I was afraid to admit homosexual tendencies. But even of greater importance, I could not reconcile the idea of falling from God's grace, nor could I handle my parents finding out. The consequences would be devastating. Maybe I could save my career by forgetting my homosexual tendencies. Maybe I could change. After all, I was dating a woman at this time. I had been taught to never tell a lie, but I lied. I checked, no, the homosexual tendencies. After I passed my North Carolina optometry board and received my license, I was sent for Army officer basic training. I still believe that I could change or at least keep my homosexual tendencies under control. I thought that with God's help, I could overcome obstacles and have a successful career. Unlike me, a lot of the trainees had previous military experience through ROTC. I had never fired a rifle. I had never been camping or ever slept in a tent. I was so embarrassed by my ludicrous marching in formation that I asked a fellow trainee to help me practice the marching commands and steps in the evenings in the parking lot of the BOQ. By some miracle, I passed basic training, including target qualifying with the M14 rifle and the .45 caliber pistol, which was the standard issue sidearm for medical officers. So I was ready, well, according to the US Army, to defend my patients and myself in time of war. So after 6 weeks of training, I received orders from my first duty station, Ireland Army Hospital. Ireland. I had no idea the United States had armed forces stationed in Ireland. I had requested Europe as my first choice of duty stations because I wanted to travel. And now I was on my way, a dream come true. And then I reread the first paragraph of my orders. Apparently, Ireland Army Hospital was not located in Ireland, but in Fort Knox, Kentucky. The first of many realities in Army life that did not match my expectations. Okay, I can live with this fate, I thought. I would stay in the Army for 3 years at Fort Knox, improve my clinical skills, complete my military duty, and return to Hickory, North Carolina. There I would set up my practice, marry the woman of my dreams, and live happily ever after. Or so I thought. Fort Knox provided basic training for newly inducted soldiers, and due to the military draft and buildup of American soldiers in Vietnam, scores of soldiers lined up daily outside the optometry clinic. As I weaved my way through the queue to get to the front door, I was astounded with the number of patients. During my 14 months at Fort Knox, I estimated that I had over 5,000 patient encounters. But my life changed. I received orders for a classified area overseas. I had learned my lesson, so I knew the classified area was not Ireland. I was going to Vietnam. I flew home for a week. It was an emotionally difficult time for my mother, who feared for my safety. I tried to reassure my parents that I would be safe with God watching over me. In late May 1966, I said goodbye to my parents. My mother promised to write every day while I was in Vietnam, and she did. I don't recall being afraid of dying. After all, I was a doctor in the Medical Service Corps, not in infantry. What I was afraid of was being punished and disgraced by the Army for my homosexual tendencies. I learned that a military person who engaged in consensual sex with an adult of the same sex faced a maximum penalty of 5 years imprisonment, forfeiture of all pay and allowances, and dishonorable discharge. Same-sex activity could also be prosecuted under Article 133, which prohibited conduct unbecoming an officer and a gentleman, and Article 134, which prohibited offenses that undermine good order and discipline or that bring discredit upon the armed forces. In Vietnam, I witnessed the consequences of homosexual tendencies when my optometry tech, Martin, a married man, was accused of sexual misconduct with a male soldier on their way back to our camp after midnight, a midnight of drinking. Martin was brutally beaten by the other soldier, who used a rock to bash his face and head. I deeply regret that I did nothing. I did nothing to help Martin on his way to the field hospital for treatment. I didn't offer any support or express empathy for him. I was afraid that if I did support him in any way, it would cause my fellow colleagues to be suspicious of my own sexual activity, my own sexuality. There was no activity. The commander of our base camp demanded that sodomy charges be reported to the Criminal Investigation Command, commonly known as the CID. Our unit commander tried to call the CID, but couldn't get through on our field telephone. He then asked me to go to the CID and report the event. Me, a man with secret homosexual tendencies, was asked to go to the CID to report the homosexual tendencies, the investigation of alleged homosexual conduct from my assistant. With great trepidation and a heavy heart, I did what I was told. Sodomy laws remained in effect in 23 states until 2003, when the Supreme Court invalidated them. In sweeping language, the court said the Constitution protects the right of gay people to form intimate relationships and retain their dignity as free persons. Gay people have the same right to define one's concept of existence, of meaning, of the universe and the mystery of human life that heterosexuals do. State laws that demean the lives of homosexual persons were no longer valid. But that didn't apply to the military. It was not until 2013, just 8 years ago, that Congress passed and President Obama signed the bill that repealed the military's stigmatizing and discriminatory ban on private consensual sexual conduct, defined in Article 125 of the Uniform Code of Military Justice as unnatural. Well, back to the 60s. My new unit, the 221st Medical Dispensary, formed at Fort Lewis, Washington, the same Army post where my daddy had been medical corpsman during World War II, some 20 years earlier. I joined the newly formed dispensary staff, which consisted of 3 physicians, a dentist, an administrative officer, 17 medical corpsmen, and I filled the optometry slot. On July 7th, 1966, our dispensary personnel flew from Seattle to Oakland, California, boarded a ship, which later briefly docked in San Diego to pick up 2,000 Marines, and off we went on our cruise on the Navy ship Gordon. Idleness on the ship gave way to rumors. Without a cell phone or the internet, it was difficult to separate speculation from fact. Most of the rumors were war stories, but I remember a particularly unbelievable story about the systemic slaughter of 8 student nurses in South Chicago, not far from where I had gone to optometry school. The story was that a young man broke into an apartment building and over a period of hours stabbed or strangled 8 nurses after leading them into a room one by one and raping the last victim. Of course, the hideous story was not a rumor, and the killer was Richard Speck. Mass killings are not a new phenomenon in our country. And the beat goes on. A choppy ocean caused our transport ship to sway as we approached Cameron Bay, 23 days at sea. While plumes of smoke rose from the distant mountains, overhead, I heard the sound of fighter jets. War was not far away. Soon our dispensary unit was sent to Phan Rang to support the 101st Airborne Division. Although I had packed all my equipment to set up the optometry clinic while I was still at Fort Lewis, none of it was there, nor would it ever arrive. I had nothing to do. Within our dispensary, the busiest clinic during sick call was the Sexually Transmitted Disease Lab, the STD lab. Since the lab was understaffed and to help occupy my time, I volunteered to draw blood and take smears. I think I was the first optometrist, and maybe the only one, to routinely draw blood labs in Vietnam. During this time, I also witnessed my first public health program. Docs from the nearby airbase schedule routine visits to educate, conduct physicals, and draw blood from sex workers at the local brothels. If the brothels refused to comply, they were placed off limits for the soldiers. There were other firsts for optometry and me during the year in Vietnam, but I'll spare you the details, which you can read in my book. Meanwhile, I discovered a phoropter and stand and some other equipment not in use in a nearby Air Force Base clinic and asked for it. I also asked my parents to mail my ophthalmoscope and retinoscope. For the remainder of the year, I provided eye examinations for soldiers, airmen, and some local civilians. Dave, will you show the first slide? Okay, so here we are. Here are the troops lining up during sick call. So I did a lot of vision screenings and ordering glasses, but if they needed an entire exam, I rescheduled them for later in the day, but this was sick call. Slide 2. Yes, that was me. Can you believe it? Time changes things. Slide 3. So here I am with the 3 maids that work for our clinics. We had 3 Quonset huts, and so I'm not sure why we needed all this help, other than it was dusty all the time. That the land was cleared of all vegetation before they put down the Quonset huts and the tents. So there was red dust blowing all the time. And the maids were constantly cleaning our equipment, cleaning the clinic. And you notice we have flowers. Those are portulacas. I found them growing wild in a field nearby and transferred them into the flower beds in front of my tent. I received quite a bit of ribbing from my fellow soldiers about that. But there you have it. Flower power in Vietnam. Okay, those are in all my slides for now. I went on to Army assignments in North Carolina, Germany, Texas, and Oklahoma before getting out. And getting out is the key word, because I was tired of living as a closeted gay man. Although I did return to the military 10 years later, which I talk about in my book. In 1973, after receiving an honorable discharge, I traveled for 6 months in the US, eventually settling in the progressive town of Chapel Hill, North Carolina. During that first year in Chapel Hill, my interest in politics and healthcare grew, leading me to enroll in the university's School of Public Health, Master's in Health Administration. I never forgot, while growing up in rural North Carolina, that no one in our community had health insurance. My parents and neighbors worked for minimum wage with no benefits in textile mills and furniture factories. I can't imagine how they afforded doctor visits. In fact, sometimes they couldn't. I remember one evening being taken to the house of a nurse for a shot of penicillin, the cure-all drug. She said she had disinfected the needles by boiling them in a pot of water on her kitchen stove. Well, the result was I contracted hepatitis, a profound memory of the consequences of the lack of access to appropriate health care. So I thought, with a degree in health administration, it would enable me to be part of the healthcare policy changes that needed to be done in our system in Washington. I believed it was a moral imperative to provide affordable health care for everyone. While in Chapel Hill, I also became an advocate for gay rights. I believe it was to help make up for those years of suppression and living in the closet. Realizing my own struggles, I wanted to make it easier for gay students to come out and for others to accept their gay friends and relatives. I became one of the founding members of the University of North Carolina's Carolina Gay Association, which was eventually recognized as an official student group. Our monthly meetings, which were held in the Student Union building, made a visible statement that we were part of campus life. To dispel misinformation and hopefully prejudice about gay people, I was a member of our speakers group, which went to classes at UNC and other universities to tell our stories and answer questions. I also volunteered as a DJ for our monthly dances, held on campus and open to all, including heterosexuals, a first for the university. Remember, this was 45 years ago. It was the summer of 1976 and subsequent events that transformed my professional career. Part of my master's program was a summer practicum at Indian Medical Center in Phoenix, where I worked in the eye clinic with ophthalmologists and optometrists. After that summer, I visited with Dr. Lester Kaplan, who was the Indian Health Service optometric consultant, and whom I consider the father of Indian health optometry. I told Les about my summer experience at the Indian Medical Center and inquired about a clinical job at IHS. After a lengthy discussion, Les advised me that I could be of more service to optometry in health policy position in Washington. Thank you, Dr. Kaplan, for your wise counsel and getting me back on track. Some months later, as a result of a recommendation from an optometrist at that clinic in Phoenix, I was asked to join the American Optometric Association task force to evaluate the optometry programs at the Indian Health Service and make recommendations. At a subsequent AOA Volunteers National Meeting, I met David Lewis, who was a staffer in government relations in the Washington, D.C. office. He asked me if I was interested in working for AOA, and I said no. I don't think they pay very much. Eventually I did say yes, and I was right. The pay was lousy. My salary the first year was $17,000. So after graduation from UNC, I was hired as AOA's Assistant Director in Government Relations for Public Health. I was clear with AOA from the beginning that I was gay. I was not going to hide my identity from another employer. A few months later at the office Christmas party, I brought my male date. No eyes rolled, no heads turned. I kept my job. The 1970s were a heady, hopeful time for potential healthcare reform. Jimmy Carter had been elected president, promising reform with universal national health insurance. Carter, who grew up in the rural South, the son of a nurse, knew firsthand about poverty and the lack of health care. Carter wanted a role for private insurance, but also proposed to expand Medicare coverage. He became embroiled in a bitter fight with Senator Kennedy, who wanted to phase in comprehensive coverage by a single payer system like Medicare with individual and employer mandates. Does this sound familiar? There was no compromise. Does that sound familiar? Today in politics in Washington. Kennedy withdrew support of the bill, and the bill died in 1980. It was the first but not last of my disappointments while working on health policies in Washington. A dozen years later, another former Southern governor, a son of a nurse, Bill Clinton, was elected president. He too tried and failed to pass comprehensive health legislation. But in 2009, some 30 years after Jimmy Carter failed, President Obama signed into law the Affordable Care Act. Not perfect, and work remains to be done. In the 1980s, my interest in public health and access to services became personal when many of my friends became sick and died of AIDS. There was fear and uncertainty at the beginning of the AIDS epidemic. In 1985, at a National Institute of Health sponsored AIDS seminar, I met Dr. Anthony Fauci, who had been recently appointed head of the National Institute of Allergy and Infectious Diseases. Yes, the same Dr. Fauci, who now heads up our nation's response team for COVID pandemic, and I believe must have learned valuable lessons from our nation's slow response to the AIDS epidemic. With increasing misinformation, which caused some health providers to shun patients with AIDS, a few ODs, including myself, recognized the public health issue and crafted guidelines for optometrists with AIDS patients. Those other ODs were Dr. Ed Marshall and Dr. Roger Wilson. We submitted the guidelines to the American Academy of Optometry, and they were adopted. Over the years at AOA, I was fortunate to have bosses who did not micromanage. With no specific action steps, I was given a goal to work toward. Assure that optometry has a seat at the table for public health policy with federal agencies and national organizations. That's it. Those agencies ran the gamut from the obvious, the Department of Health and Human Service, Centers for Disease Control, the National Eye Institute, but also took on challenges at the Department of Transportation, the Department of Education, and the National Center for Health Statistics, to name a few. Every time my boss asked me to consider taking on another job, I said yes. It made my work interesting and fulfilling. I want to share a couple case studies of policy issues and outcomes. The first is diabetes. National health policies excluded optometrists from the management of diabetes. The Centers for Disease Control and the American Diabetes Association set guidelines for care of patients with diabetes. Their guidelines stated the importance of getting an annual eye examination by an ophthalmologist. Why omit optometrists? Well, because medicine has made the rules for patient care forever. Optometry is a young profession by comparison, and it was only the first state law to permit optometrists the use of diagnostic drugs was passed in 1971. We got nowhere talking with staff. How could we educate CDC staff and members of ADA that optometrists improve access to eye care and are able to diagnose diabetic retinopathy and other ocular conditions? Well, the AOA's Public Health Committee designed an exhibit highlighting OD training and ability to manage patients with diabetes and the value of early ocular diagnosis. We took that exhibit to the annual meeting of CDC's Diabetes Care Conference, where there were state representatives from all the state diabetes programs. Along with the volunteer ODs, we staffed the exhibit and answered questions and gave away fact sheets and freebies. Working the exhibits for many years offered the opportunity to network with others who also wanted to improve care for patients with diabetes. We took the same exhibit to the American Diabetes Association and the American Diabetes Educators annual meetings, and always with optometrists at the booth to interact with attendees. Finally, in 1991, some 2 years after the last state had passed their diagnostic drug law, enabling optometrists to use diagnostic drugs, the CDC changed their guidelines to include optometrists in the management of patients with diabetes, but not the influential American Diabetes Association. I met frequently with the medical director of ADA. Although their national office was 2 blocks away from the AOA office, we were miles away on this issue. Nothing changed his mind that only ophthalmologists should be diagnosing eye disease until he had an eye examination by an optometrist at his Kaiser HMO. That exam changed everything. He said it was the most thorough eye exam he had ever had. So after years of lobbying ADA to change their guidelines, and 4 years after CDC changed their guidelines, an eye examination by optometrist caused the ADA to change their guidelines to include optometrist or ophthalmologist examinations. 3 years after the ADA decision, the Diabetes Quality Improvement Project released a comprehensive set of diabetes-specific outcome measures to be adopted by purchasers of healthcare. And I worked to ensure that the report stated the exam must be performed by an eye care professional, ophthalmologist or optometrist. Perseverance pays. Second case is health maintenance organizations, HMOs. In the 1970s, opportunity for optometrists to work in multidisciplinary practices was beginning to grow. Optometrists who wanted to work in alternatives to private practice had opportunities in the military, the Veterans Administration, thanks to Dr. Ken Myers, Indian Health Service, thanks to Dr. Les Kaplan, and the new opportunity for health maintenance organizations, thanks to Dr. Lou Catania, who was a guiding force. As you know, Lou was a recent Myers Lecture awardee. I just mentioned that the medical director for the ADA went to an optometrist who worked for an HMO. That was not always the case. HMOs initially hired only ophthalmologists. Beginning in 1978, I staffed an AOA project team, which began working on improving access to vision services by optometrists working in HMOs. We began by publishing a HMO how-to manual for optometrists. We also realized that a barrier to hiring was a lack of evidence that optometrists were qualified and could help improve access to eye care. AOA hired Interstudy, a Washington-based research firm, to assess the current status and potential cost savings for HMOs to hire optometrists as the primary entry point for eye care. I was the staff consultant for the project. The study helped make our case, and today many of these work for HMOs. One of the most important examples of the power of optometrists at the table is embodied in the American Public Health Association. APHA is a worldwide organization representing over 30,000 public health workforce. Beginning in the 1960s, AOA and optometric leaders, most notably Dr. Hafner and Dr. Peters, began efforts to gain visibility and support for optometric care within the framework of public health. By 1977, during my first year at AOA, 2 optometrists were elected to the APHA Governing Council, representing the medical care section. That was a step toward providing optometry a seat at the public health table. By 1979, the APHA recognized the new vision care section, in which optometry, ophthalmology, and others would work together to advance vision care in public health. This accomplishment was possible because of the efforts of many optometrists and our public health colleagues. AOA allowed me to play an overall organizational role to help accomplish this. Over the years, APHA has supported more than 20 vision public health policy issues, such as the elimination of Medicare policies, which restricted reimbursement for optometric services. This support by APHA was helpful in lobbying Congress to change the law, which passed in 1986, which allowed optometrists to be reimbursed for treatment of eye diseases under Medicare. In 1990, APHA's Governing Council, which is composed of physicians, physician assistants, nurses, dentists, health educators, and others, passed a resolution urging state legislatures to update their optometric practice acts to permit optometrists the use of therapeutic pharmaceutical agents, TPAs. This resolution was bitterly fought by ophthalmology, but we prevailed because of our partnership and friendship over the years with public health individuals and organizations. The support by APHA members, including legislative testimony by the executive director, was helpful in lobbying efforts to expand optometric laws in all states. There are more case studies, but I'm aware of the time. Before closing, I do want to name AOA and its volunteers that work to improve access to vision care in federally qualified community health centers. Again, AOA began by exhibiting at the annual meeting of the National Association of Community Health Centers. I especially want to call out the work of Dr. Roger Wilson to increase optometric services in CHCs throughout the nation. The AOA also signed a memorandum of understanding with the National Association of Community Health Centers to work on legislation to include loan forgiveness for optometrists practicing in underserved areas. Although we worked on this issue for years, it was a big disappointment that it did not occur during my career. During my 34 years in Washington, there were victories and disappointments. Changes in legislation and policy is a slow process. My hope is that over the years, I made a difference. Whether in representation, in optometric research, or in vision care services, I did my best to bring optometry to the table, but I did not do it alone. Public health is a team sport. In my judgment, we brought about the most significant changes in health policy when colleagues from varied disciplines work together toward mutual goals. I owe so much to so many colleagues who helped push boundaries. Collaboration, not only with optometrists, but with other health professionals, enabled achievements which I believe did improve the visual health of the public. So my sincere thanks goes to all my colleagues through the years for their support, friendship, and contributions. The following people are but a few of those whom I'm fortunate to interact with and whom I consider the ones who made a difference in my professional life and advanced optometry and public health. Sandy Block, Dan Vince, Les Kaplan, Tony DiStefano, David Lewis, Ed Marshall, Bob Newcomb, Joe Ruskowitz, Kirsten Thompson, Roger Wilson, Shu Wong, Satya Verma, Carla Zadnik, and there were many more. Forgive me if I didn't mention you, my friends. Last but not least, I want to thank my husband of 13 years, my partner for 37 years, Tony Saldana. Tony was a Spanish folk dancer with a Washington dance group, which frequently performed for guests at the Spanish and other embassies. And I had my chance to accompany these dancers when they performed for King Juan Carlos and Queen Sofia of Spain. The Spanish music was extremely difficult, and I gave up on performing it. I missed my chance to perform for the Lady of Spain. And now, just when you think you know more than you want to know about me, I want to make something public you may not know. I'm a card-carrying member of Kappa, the Closet Accordion Players of America. Yes, I am a closet or former closet accordion player. So forgive me, Lawrence Welk. Forgive me, Myron Floring. I now want to make up for that missed opportunity I had way back in Washington. This is for you, Lady Sofia, Lady of Spain. A very short version. That's all, folks.
Oh, John. How can I thank you enough? From truth telling to history lesson to public health advocacy to accordion playing. I don't know that I've ever cried myself during a Myers lecture before, but you certainly evoked that. So I certainly can't top that, but we do have a couple of questions if you're up for a couple of questions.
Absolutely.
Great. So one is from someone you don't know, but should. Bryce St. Clair, who was an alum for a couple of years ago at Johns Hopkins University. And he writes, where do you see opportunities where there is no advocacy for the profession taking place? That is, are there current positions you wish some of us would fill?
Yes, good question. Through the years, I tried to convince optometrists that they should be in health policy positions in the federal government in Washington, in the VA, and Department of Health and Human Services. If we had had an advocate in the Department of Health and Human Services for community health centers, for instance, in that program, we would have gotten so much farther. I found through the U.S. Public Health Service, there were dentists who went into policy positions in Washington, and nurses and health educators, but very few. There were some at Federal Drug Administration. We know that from in contact lens specialty area for FDA. But if we had more optometrists interested in health policy who would go through the Public Health Service Corps, that's one avenue that has opportunities for sure.
That's fantastic. I've also observed we've never had anyone with an OD degree on the staff at the National Eye Institute. Lots of PhDs, even a dentist along the way, but we have yet to have an optometrist in one of those roles. So I would,
And that seems unnatural too, with optometrists doing research and having academic credentials, that there should be a path there.
it does, yes. So our next question is from Howard McAllister, old friend of yours.
Hi,
It says,
Howard.
John, excellent lecture. Would you, and Howard is also our alum and this year's Peters Award-winning lecturer for the American Academy of Optometry. Would you address the impact of DPA and TPA experienced by optometry officers in the uniformed services on subsequent laws allowing such rights in the civilian world?
Thank you, Howard. I think you know this all too well, being a career military person as well. I think it was during Vietnam that we realized, some of us in optometrists realized, that we could be diagnosing more disease of the retina if we had diagnostic agents. And so people like John Amos, who came back from Vietnam, was one of the people, along with Howard and others, who brought that experience of the military, where frequently we also were in, not just in Vietnam, but in other clinics in the military. We worked in eye clinics where optometrists and ophthalmologists worked in the same clinic, and where we learned from ophthalmologists, and where we realized we were capable of using ocular drugs to the well-being of our patients.
Fantastic. Next from Katie Exline. She is our second-year class president, and I want to take this opportunity. I noticed a number of students' names on the attendees list, and I know finals start on Friday. So thank you, students, so much for your time. I think I even might have seen a prospective student on that list, which is really great, getting an early start. So Katie says, thanks so much for your time, Dr. Widener. As young optometrists just entering the field, how can we best invest in optometry throughout our careers?
Invest, is that the word?
Yeah, invest. Yeah, invest their time, their energies, tithes, whatever you might think appropriate.
Thank you, Katie, for taking time to listen to this tonight when you had other things I'm sure you could have been doing. Well, I think it points to me that optometry is a wonderful career. Seeing patients, the satisfaction you get at the end of the day when you know you've seen X number of patients and you've helped them to see, you've discovered ocular diseases, you're providing treatment. It's a great feeling. And that's very different in health policy, where at the end of the day, at the end of 4 years, at the end of how many years, you may not have that feeling. I think that it's important to maintain clinical skills no matter where else your optometry or your career may take you. That's why for 15 years, I was in the Army Reserve. I saw patients 2 days a month to keep up my clinical skills. So you could invest, I think investing in the community, if you go into private or other practice in a community, I think getting involved with your community is a good way to invest your skills, you know, by volunteering with organizations, getting yourself out there. The public health network is I think is a good way to build a practice, in fact, through mutual interest of public health within a community. Every community in the United States has a health department. I served on the board of our local health department for, I don't remember, 5 years at least. And it was a great way to meet other policy people in the community and other health providers. So check out the possibility, if you do go into private practice or any practice in your community, check out the possibility of maybe volunteering for your local health department.
Fantastic. And our own beloved emeritus professor, Jackie Davis, who I know you know, who won, let's see, a Vision Care Section APHA award this year and became a diplomate in the section on public health and environmental optometry from the Academy last year, writes, thank you for this wonderful walk through public health optometry and personal triumph. You are a treasure. And then she has a hard question for you.
Oh, gosh.
Do you have suggestions on how to increase the involvement of optometrists in the APHA?
Wow, good question. Good question, Jackie. You know, the interest of optometrists in APHA has waxed and waned over the years. I gave you an example of how helpful having that visibility within the vision care section within APHA is to passing public health policies, which can be used to improve access to eye care and certainly affect policies at the federal level, whether in CDC or whether in state legislatures. So how do we get optometrists? I guess we just keep repeating stories similar to what the story I told about how, you know, to have friends, you have to be a friend. You know, for us to have the support of APHA in our endeavors in vision and public health, we have to be a friend. That means being a member, even if it's only paying your dues. You know, you will be exposed to public health in that way, as well as you will show the strength of our section as part of the bigger public health framework.
And you may just catch the public health bug just by paying your dues, and then suddenly you meet some people and you go to a meeting, and gee, that's how some of this stuff gets started from those grassroots. All right, I think that's the last of our questions. Jeff and Joyce, if you want to turn on your camera. And John, I think you have your award.
Yes, I do.
Thank you, Carol Wilcox. We are so well coordinated
the
here.
Internet, you're giving it to me now, right?
I'm giving it to you right now. I'm just handing it through. And I do certainly want to thank Joyce and Jeff once again for giving us the opportunity to expose Ohio State optometry and beyond. I also noticed, John, several people you invited were also on tonight to expose us all to people whose voices Ohio State optometry may never have gotten to hear without you. So Jeff, do you want to say a few words? I know we don't usually do this when we're in person. I don't mean to put you on the spot, but I know you're never at a loss for words. So I'm vamping a little bit just to give you a second.
Well, first of all, congratulations, Dr. Wagner. We really appreciate you sharing your history, and as you did in the interview, learn a little bit more about you, and we just congratulate you. Thank you for what you've done in public health over the last decades, and sharing your story. Carl, it's just been a privilege for us to share some of these giants within the profession over the last 13 years. We look forward to another 13 or 50 or whatever it is, and being able to bring some of these giants of the profession into Ohio State and into the family, so to speak, and let them have a voice and share their stories. So that's what we hope to do. So thank you so much.
Thanks to both of you. And go ahead, John, I'm sorry.
No, I just wanted to thank them very much for selecting me as the lucky 13th person. Thank you.
And I'd also later, both this lecture as well as the Actors Studio interview that Jeff did with John last Friday will be available on the college website. So if you want to hear more and see John Whitener unplugged, if you can imagine, you can watch that Actors Studio interview. It was also great fun. There was no accordion, so you had to watch this to get the accordion. Thank you so much, John, for honoring us with your presence. And love to Tony. Everybody, thanks for attending. Have a wonderful evening. Thanks, everybody, for your time and engagement.
Thank you. Thank you all. Thank you all for staying. Bye now.